we have a quick discussion. We have a quick presentation about the funding of this, and I would just like to share it with you briefly. This is one of our many J.R. Williams lectures that we have been offering for the last several years. The J.R. Williams lectures are, well, we'll talk about that in a moment. This lecture is, of course, Beyond Best Intentions, the Ethical Volunteering in Global Health. So the J.R. Williams lectures are a series of lectures set up by a graduate of Tulane University School of Medicine. The series that we have honors the legacy of J. Richard Williams Sr., who was a well-known, well-loved internist and oncologist in Selma, Alabama, who did his training at Tulane School of Medicine. Initiated in the fall of 2013, this is an endowment that supports lectures generally on the topics of spirituality and health at Tulane University School of Medicine, focusing on the art of creating a compassionate and trusting relationship between patient and doctor. This is something that Dr. Williams really represented himself. He loved medicine. He was the kind of doctor who would do anything for his patient and had an interest in the impact of spirituality on health, particularly the positive impact of spirituality on the well-being and continued health of those who have suffered the loss of a loved one. The J.R. Williams Sr. Endowed Lecture Series Endowed Lecture Series then is set up to broadly honor this legacy, and we are very grateful for this endowment that allows us to bring in speakers along general topics in spirituality and medicine. We are also co-sponsoring this with our master's program in bioethics and medical humanities. I'm not going to talk your ear off about this. You can find us at tulane.edu/bioethics on the web and on YouTube. Basically, we have two different tracks in our master's program, one in bioethics and one in medical humanities, though all of our students take materials from both of these tracks. We either offer a 1 or a 2-year master's program, and we can also offer that in a part-time fashion for faculty development as mid-career professionals. We also have this as an integrated dual degree in our MD 4-year program, so that at the end of 4 years, you graduate not just with an MD, but in fact with an MD and an MS. And finally, we offer 3 different certificates, graduate certificates in clinical ethics, research ethics, and medical humanities. Each of these is only 12 hours apiece, and they can be stacked together. So if you take a certificate in, say, clinical ethics and find it extremely interesting, you can, in fact, use those same credits to build towards the master's and earn both the certificates and the master's. Like I said, I'm not going to talk your ear off about that. There are lots of ways that you can find us. You can find us on the web, tulane.edu bioethics. You can email either me or Dr. Offengendon, and either of us would be more than happy to answer any questions that we have. That's the last I want to say. I am happy to hand it over now to the Bioethics Interest Group to introduce our speaker for the day.
All right. Hi, everybody. Well, you're seeing my back, but I'm showing you my face. So today we have Dr. Sarah Rodriguez, PhD, who's a medical historian who teaches in the Global Health Studies program in the Weinberg College of Arts and Sciences in medical education for the Feinberg School of Medicine, and in the Medical Humanities and Bioethics graduate program, all of which are situated at Northwestern University. Her research interests include the history of reproductive health, the history of clinical care, and the history of the ethics of clinical research, especially regarding surgery. She's published multiple articles and 2 books, including her most recent, The Love Surgeon: A History of Trust, Harm, and the Limits of Medical Regulation. Her current research focuses on the history of hysterectomy and on the history of global efforts to reduce maternal mortality. Without further ado, Dr. Rodriguez, please take the stage.
Thank you so much for having me and inviting me. And I intend to leave time for questions at the end. So please save questions or feel free to think of some questions as I share my topic with you all. All right, so share screen, share. No, wait, slideshow. All right, so here you can, this is my title, so thank you very much for the introduction. I'm going to be talking about volunteering in global health with you all today. And just as a precursor, I have nothing to disclose about what I'm going to, no financial ties to disclose about this talk. So before I talk, I'm going to actually give some general terms before I start speaking more topically about, specifically about ethics of volunteering in global health. First, a couple of terms I'm going to be using. So I'm going to be using the low to middle income countries, the LMIC/Global South terms, as well as high income countries / Global North terms. I don't love either of these terms. I'm using them because they've become sort of standard within global health talk. But just so you know that those are the terms I'm going to be using, even though, again, they have their own problems. But just to sort of differentiate between sending institutions, which typically are global north / high income countries for volunteering, and host countries, which are typically the low to middle income countries. Second, another definition to think about is, what is global health? So first, global health, the classic definition, the common used global definition, I'm going to caveat that by saying common within the global north. This is the Copeland definition from 2009. And that's, it's a practice that places a priority on improving health and achieving equity and health for all people worldwide. This idea, this notion of global health as being something somebody engages in has really grown in the last few decades. As they go on to say, it's fashionable, it provokes a lot of interest, and it's not just philanthropic, even though that's a large part of this. There's also a major government component of this. I'm also going to say, even though this is a recent phenomenon, the origins of global health are much older. It's derived from public health and international health, which in turn evolved from tropical medicine. And I'm going to return to that because the one thing I'm going to say at the offset, as you guys noticed in my introduction, is I'm a historian. So we're going to be talking a little about history, about what's going on here too during my talk. So second, another definition I'm going to put out, what I'm going to focus on today are something called STMMs. They're also called short-term medical mission trips. Sometimes they're called medical engagements. And this includes a whole host of sort of activities. Right, it could be medical missions, it could be volunteer internships, this can be medical or nursing student rotations, it can be medical education or medical brigades. This can be missionary, meaning very faith-based, or it can be nonprofit without a faith-based. It can be grassroots engagement, or it could be academic engagement. So it's a whole scope of engagement. We talk about these short-term medical mission trips, which is what I'm going to really focus on today. So what is it about these short-term medical mission trips? What else sort of defines what we're talking about here? So these have also grown exponentially since the early 2000s. And so thinking about who goes when we talk about who's partaking in these short-term medical mission trips. So largely we're talking again about global north countries being the sending and the host countries being those in the so-called global south countries. So within the global north of sending, of who goes, primarily it's the United States and people from the United Kingdom, as well as Canada and Australia. Those are the top 4 countries for sending volunteers to do these short-term medical mission trips. How many people go? These are older pre-pandemic numbers. Probably it's still a little unclear of where we are right now. But if you think about this as a ballpark of how many people go from these 4 countries in particular, it's between 800,000 to over 1 million people from the United States just are going on these short-term trips. Okay, and how long do they go for? So short-term medical mission trip can be anywhere from 1 day to 2 years. So the amount of time we're talking about is pretty flexible for what counts as a short-term medical mission trip. The emphasis, though, is on short. So the 2 years would be on the extending the longer sort of part of this. It's mostly a shorter term. So typical might be a week or a month. So whoops, that's too fast. So why do people go on these short-term medical mission trips? Why do people from the United States, the UK, Canada, and Australia go? And as Wendland et al. Put it, right? Because a lot of people, there's this inundation of disease and trauma and indecent poverty that come from certain parts of countries that we typically label as the global south or low to middle income countries. And so people in the United States and European countries often experience this powerful surge to help. They want to go contribute. And as they put it, people with medical or nursing training, already highly action-oriented individuals, may be especially driven to intervene in bodily suffering, right? This compulsion to say, I want to help. Many, many people go into medicine because they want to help people. And so this is a way they feel like I can particularly maybe give back in my volunteer is if I do a short-term medical mission trip. Okay, so as this quote puts it, I think quite succinctly, right? Helping people in need and being of service. I had these inclinations from the beginning that I need to do something for other people without expecting anything in return. So this is one physician commenting on why they participate in short-term medical mission trips in another country. And so that we can say is those sort of best intentions, right? That people go on these trips because they have the best intentions. They really want to help. They want to alleviate suffering that they're seeing in other places. But this isn't always the reason that people are going on these short-term medical trips, okay? So maybe we know some of the reasons are, it's because it can be a challenge for people. If you're coming from a high healthcare resource setting, and you're going to a place maybe without the same high resource area, right? It's a challenge because you have to rely entirely on your clinical skills. I can't sort of order up tests, okay? Or my initial draw was I enjoyed doing clefts. We don't see that many clefts here in the United States, but there is an unlimited number of clefts in those countries. Okay, and I'm going to actually focus on that quotation, right? Because this gets to a second definition of global health, I think, which going down this, we don't see many clefts here in the United States, but there's an unlimited number of clefts in somewhere else, right? Somewhere where I am not. And so as Kinkowski put it, I think in a pretty important article, global health as a field is not distinguished by its aspirations, methods of research and practice, intervention strategies, or even geographical area per se, but rather by a particular relationship between its practitioners and its recipients. A person engages in global health when they practice public health somewhere else. They do not call it home, right? I have to leave the United States in order to do global health. And in particular, I have to leave and I get to do something that maybe I'm not able to do in my home country. So thinking then beyond best intentions, okay? Best intentions, as I always tell my undergrads when I teach global bioethics, best intentions matter. Having good intentions profoundly matters, but you could do some unethical things with the best intentions, okay? So we need to think beyond best intentions and also think about actions. Okay, so and as again, this article by Kinkowski said, right, there's a sense of duty I would like to address, and I have really good intentions, but as they say, well, the aspirations behind much global health work are no doubt justified from an ethical perspective. The imperative to practice public health somewhere else can often produce unintended, in some cases, harmful consequences. Okay, so what does that look like? So one of probably of all these unintended consequences, probably of the sort of major concern that you see within the medical literature is this practicing outside the scope of practice. So going back to that, I don't see very many clefts in this country, right? If I go somewhere else, I can practice and see, can I actually repair a cleft? Okay, and I might not be able to do that here. So, and I might not be able to actually do that here because it's outside my scope of training. But this idea that if I go somewhere else, it's sort of challenging me. Perhaps that challenge is also, I'm going beyond my scope of practice. So one small study found that about half of those people in this small study had been asked to perform outside their scope of practice when they were on one of these short-term medical mission trips. Okay, and within that group, 61% said they had actually performed outside their scope of practice or outside their scope of training. So why did they do so? There were a couple of reasons the researchers found. One, there was a mismatch with the host expectation. So the volunteer doesn't have the sort of skill set or doesn't have the training for wherever they've actually volunteering. So maybe they're in internal medicine, right? And they've suddenly been put in a pediatric clinic, okay? Or there could be a suboptimal amount of supervision. or an inadequate preparation to decline requests, right? How do you say, no, this is actually outside my scope of practice. I don't have the training to do this, either because I'm a practicing clinician and I haven't delivered a baby since my 3rd year of medical school, or, right, I'm a trainee still, and I've not been trained how to do this. There can also be a perceived absence of alternative options or a perceived inadequate level of staff, equipment, or resources. If I'm there on a short-term medical mission trip, if I'm only there for a week, I might not fully understand the whole situation. In fact, I probably don't, because I've been there too small of a time to really understand what's going on and if there's a shortage of staff or not. I want to be able to perform a procedure or technique I was not familiar with. I did not seek adequate assistance when I needed it, or there could be an emergency situation. And an emergency situation, however, could look like an emergency situation to the volunteer coming from a sending country. But the host situation, the host country, the host community might not actually see this as an emergency. So there could even be a difference between what is an emergency and what's not an emergency, and then how someone's going to intervene or not intervene in that. So practicing outside scope or beyond your competence, or doing things abroad you would not do at home, or you legally can't do at home, right? This is on an individual level when we think about concerns, ethical concerns about short-term medical mission trips, about volunteering within global health. This is at the individual level. We can also see at this individual level, it plays out in things like a failure to understand the language or the context or the culture of where someone is visiting, and providing medical treatment without actually understanding where they are. And this can result in misdiagnosis or recommending a therapy that does not even exist. So, and again, the focus with this sort of scope of practice is very much on actions of individuals and how they see themselves as being able to intervene. And this is often driven by the very wrong idea that some care is better than no care. Okay, this is where I sometimes I use the I call it my mom principle for ethics. The mom principle for ethics is, if I don't want this happening to my mother, right? If I don't want my mother being treated, delivered, whatever it is, by someone who has no training or no experience, then probably I shouldn't be doing that either. Okay, so mother, you can insert someone I care about, obviously, but this idea that some care is better than no care is a falsehood. But sometimes this sort of intervention is driven by that notion. Okay, so then these individual levels, these assumptions that sort of drive people to maybe doing things that maybe they really shouldn't be doing ethically, are driven essentially by 2 assumptions. These short-term medical mission trips and these interventions are often driven by 2 assumptions. The first assumption is, again, from King and Koski's article, is there's an underlying assumption that there's an expertise gradient. Okay, I'm at Northwestern, so therefore I know more than somebody else. Okay, so there's an expertise gradient that is both maybe where my training was, but also very much tied to being from a high-income country. Okay, so that it's somehow I have more knowledge or I have more expertise than wherever I'm visiting, wherever I'm volunteering. And it's also, this assumed expertise gradient is often accompanied by this perception that problems elsewhere are simpler than those at home. And I think this is really important when we think about ethics in global health volunteering, is this idea of like, well, the 2 days I'm there, I can sort of change what's going on. You might be able to make a difference. I'm not saying you're not going to, but there's an assumption sometimes that underlies that it's easier if I go somewhere else to make an intervention, right? And we need to sort of really question that idea as well. The second assumption often driving some ethically concerning behavior within short-term medical mission trips is that there's underlying global health volunteer efforts is the idea that they're going somewhere where there is no care. Okay, where they're going somewhere where there is no healthcare, there are no doctors, there are no nurses, right? And the people are entering a landscape barren of medicine or medical care. And this is very often not true. It might not look the same as care at Tulane or at Northwestern, right? But it doesn't mean that there is no care where this person is volunteering. So this assumption then supports some ethical concerns regarding volunteering at the systems level. So we think so really I'm going with here, there's 2 levels, essentially, this individual level as well as a systems level. And this one kind of bridges the 2, if you will. So at the system level, some ethical concerns about global health volunteering on these short-term medical mission trips We can think about these as real and potential harms that people engaging in global health volunteering need to be very mindful of. First is that there actually can be, with these volunteer short-term medical mission trips, there can be a displacement or devaluing of local providers. There can also be this mismatch, again, between local needs and visitor offerings. Again, what I noted earlier, right, that I'm an internal medicine, and I'm showing up at a peds clinic, okay? Neocolonial attitudes toward host communities, I'm gonna loop back to that because I am a historian. Inequitable use of funding, creation of dependency on external resources, lack of continuity of services and or follow-up care, lack of mutually beneficial and sustainable partnerships between sending organizations and host communities, as well as lack of oversight. And the ones that I have in blue, I'm going to spend a little bit more time on now, even though these I think are all important. I've just picked 3 to focus on. So thinking about this displacement or devaluing of local providers, which I don't think is often thought in the equation. If I'm going to volunteer somewhere, what does that impact for the local healthcare community? So there can be a number of things that fall under that could be ethical concerns raised with this short-term medical mission trip. First is, as a volunteer, maybe I'm belittling the knowledge and skills and practices of local providers. Okay, again, that sort of idea that I'm the expert, I'm coming in and I can just sort of belittle the skills and knowledge of the people I'm supposed to be working with, my peers that I'm working with at this or volunteering with at this clinic. Local providers not included in NGO clinical work, okay, so that maybe the NGO is running without actually any local sort of staff or local healthcare facility or more sort of locally based healthcare facility. Local providers not being asked to perform administrative tasks to support volunteers. So instead of actually, if you're a nurse, if you're a physician, right, you're asked to do something like translating, which I have on the next line, or more administrative tasks to support volunteers. By doing that, you're more than likely taking away the sort of care responsibilities that that person has. Local providers being asked to act as tour guides or translators to volunteers, that this happens, again, taking away from what they're supposed to be doing clinically, those clinical duties. Instead, you're being a tour guide or you're translating for the person who's visiting. So that could be an entire week where people aren't being seen by you. Local providers being asked to give up their clinical surgical time to visiting clinicians, again, then reducing sort of care of their own patients. Free clinics run by volunteers undercut local private clinics and local clinicians. Okay, that there's this, if there's a free clinic, perhaps I'm going to take my family to the free clinic run by the NGO, by the Americans, because A, I might think that it's better care. And 2, though, by doing that, maybe I do have the capacity to pay. I'm undercutting the sort of private practice that a local clinician is trying to maintain, or I'm not sort of being integrative with the sort of healthcare setting in the community that I live in. There can also be a perception by locals that care is better and provided by high income country clinicians, which I just suggested too. And it can also mean a reduced incentive by governments to invest in an area. Okay. And that can be that a government might see like, well, this NGO keeps showing up at this area and they're providing care. Maybe it's a couple of times a year. So we have limited healthcare dollars to be spending. Let's not spend it there because we already have, there's this NGO. We're just going to rely on this NGO to do this, where perhaps there really is need for a sustainable, a longer term clinic, but they're not investing in that because this NGO is showing up and sort of fulfilling at least a little bit of the need that's existing there. Another big focus, and I'm going to say a larger, it's become more of a buzzword in some ways in global health, is this idea of partnerships. Even though I'm going to pose a caveat, there isn't a good definition of what that looks like, but this idea that partnerships between the sending and the host institutions and sending and host countries, that there should be something that's beneficial for both parties involved. This often doesn't happen, so that's why there's a concern that this short-term medical mission trip is lacking in mutual beneficial and sustainable partnerships. Okay, this can come across in a number of ways. So it could be that it's lacking because it becomes there's no partnership. There's a burden on the host community or host clinic when the visitors come in, right? Again, that burden can be suddenly the clinicians are acting as translators or doing administrative work or driving around somebody. Okay, so this can be exacerbated then by cultural insensitivities or by the perceptions held by both host and sending participants that foreign healthcare practitioners and practices are superior to those of the host country. Okay, then the last one I'm going to touch on for that list then too, is there can be a lack of oversight of these short-term medical mission trips, both within the country as well as globally. So within the country, there might not be a mechanism for sort of even regulating, let alone even counting how many of these short-term clinics are set up, or what NGO has come up and set up a clinic in said country. There might not be oversight in a country for that. There certainly isn't globally. We have no idea the number of NGOs that are doing this kind of work. There's no count of it. Okay, so this lack of accountability, this lack of oversight is deeply concerning on a structural, a systematic sort of level, that there's nobody assessing the scope or impact of these short-term medical mission trips, right? As well as establishing standards of care for such missions. There's no sort of oversight for this. So there have been the past couple of decades, so as you see here, early in the 21st century, sort of late 20th, early 21st century, there were some people who were saying like, well, maybe we do need some ethical guidelines to really sort of lay out the parameters for what good ethical volunteering in global health looks like. So this sort of thought was coming, and again, in the late 20th, early 21st century. Before that, it was largely seen as this is just unobjectable good, right? People going from a high-income country, they're going and volunteering somewhere that there says they have good intentions, so there's nothing ethically concerning about what they're doing. But this idea that there's nothing ethically concerning, that there's no problems as long as there are good intentions, really started to be questioned in, again, sort of not that long ago, but around the sort of early 21st century, there was this idea that maybe we do actually need some guidelines, some ethical guidelines for these short-term medical mission trips, in particular to address this idea of some care is better than no care, and this idea that this is just an unobjectionable good. But I'm going to point out, most of these ethical guidelines were written by people from high-income countries or from the so-called global north. Okay, then just from a recent example, a recent examination of these, host country representation, shared perspectives within these guidelines were persistent and lacking. The majority of the 27 short-term medical mission guidelines represented ideas and perspectives of participants from high-income countries. This disregard for host perspective is promotive of neo-colonial values since it serves to perpetuate power differentials between sending and host stakeholders. So this is where I'm going to loop back to that definition of global health, and this is where I'm going to put my historian hat back on, because if you recall the definition that I gave you, the briefer definition I gave you of Copeland et al.'s widely used in the global north definition of global health, is it was derived from and evolved from hygiene and tropical medicine. But global health also derived from and is still often reflective of colonial medicine, though this is often not recognized within global health or within global health programs. And see as an example, the very edition of Copeland, who leaves out colonial medicine as part of the history of global health. Okay, so I'm going to go a little bit then into what is colonial medicine and why do we really need to actually acknowledge this history, I think, when we think about what makes ethical volunteering within global health. So first, what is colonial medicine? Here, I'm really talking about European imperial powers. I'm going to put a caveat. The United States has its own history of being an empire, but I'm going to really focus on European here. So colonial medicine, we think about this way, is European imperial powers, it was seen as a way to manage the health problems of their dependent territories, largely then in parts of Africa and parts of Asia and parts of Latin America. So colonial medicine was at its core about enabling the expansion and health of the empire. And in that sense, we have to think of it as a tool of colonialism. So as the historian Packard has laid out, there's two characteristics that we can really think of the colonial medicine that are useful for thinking about global health today. First is colonial medicine was largely and primarily concerned with the health of colonizers and the economic interest of the colonizers. And there's two consequences of this. First is the production of goods, whether we're talking of goods or of mining or et cetera, was more important than the health of colonized people. And second is health services were located in urban areas because by and large, colonial medicine was for the colonists the colonizer people, right? And not the colonized people. That's why mostly it was urban areas, and the focus really was on supporting the health of those who were colonizing. Second, colonial medicines tend to be very narrowly technical, and that's because health was largely defined as an absence of disease. By and large, colonial medicine was very concerned about infectious diseases, particularly parasitic diseases, because those are what interrupted trade. Okay, the first international sort of health meetings we see are in the 19th century, and they are really concerned about cholera because cholera outbreaks interrupt trade. Okay, so we still see this within colonial medicine. What is of concern is the infectious diseases. It's not sort of primary care, it's about the infectious diseases. So when colonized populations actually typically engaged with sort of biomedicine, European medicine, it was typically because there was a disease outbreak of a parasitic nature. So colonial medicine then supported the empire, and this means it protected imperial military forces to enable conquest and to secure or to maintain territories. It helped facilitate occupation and colonial expansion. It helped safeguard commercial interests. It improved productivity of, let's say, populations who were enslaved or indentured or coerced workers. It improved colonial relations to stave off unrest and or rebellion. We see this particularly in the 1920s and the 1930s, and then again a little bit in the 1940s, because we see these really large waves of independent movements, and colonial medicine was a way for colonizing countries to say, hey, there is something good about being a colony. You get colonial medicine. And then finally, the exercise of colonial power over indigenous populations. Okay, and that's why I'm going to loop here a little bit too, because some of the motivation of colonial medicine was this idea that it was helping colonized populations who were seen as uncivilized or unclean or primitive. And this is really striking in the Pear soap ad that's taken from Kipling's famous poem of the white man's burden, right? There's a white gentleman washing his hands, and then you can see in the corners of various sort of parts of the colonial empire that are supposed to be represented, that sort of colonial, the colonial mission is helping various populations around the world. I'm also going to point out Kipling's poem, even though he was British, right? The white man's burden is actually about the United States, and the white man's burden about building the Panama Canal. Okay, so this idea of a civilizing mission is also a large part of colonial medicine. So rationales for colonial medicine: it reinforced political and social stratification between colonizer and colonized, asserted cultural superiority by colonizers and or sometimes racial superiority between colonizers and colonized. There is definitely a saving via civilizing work. This is both within missionary medicine as well as the government missions. And again, there's a moral patronizing justification for civilizing populations. Colonialism does have an element of that colonization helped populations, and colonial medicine reinforced that. So I teach global bioethics at Northwestern. I also teach history of reproductive health. I also teach history of maternal health. And for all of my classes, I use Packard's 6 persistent trends in the history of global health to think about what are we doing now in global health. And when I teach global bioethics, I say, if you hear one of these in something you're doing today, it doesn't mean you shouldn't be doing it, but it definitely means you should take a step back and think about what you're doing and probably reconsider, or at least really critically think about what you're doing. So first is health interventions have largely developed outside the countries where the health problem exists, with few attempts to seriously incorporate local perspectives or community participation in the planning process. We definitely saw that within colonial medicine, like we saw all of these, and we still hear these today in global health. So we also hear that health planning has privileged approaches based on the application of biomedical technologies that prevent or eliminate health problems one at a time, as opposed to a more horizontal approach of sort of introducing, for example, primary healthcare or clean water. Okay, and that goes to number 3. Little attention has been given to supporting the development of basic primary healthcare services. 4 is the planning of health interventions have often occurred or seen as needing to occur in a crisis environment. So there's an imperative to act fast, act quickly, and those then set themselves up to be short-term interventions. 5th is global health interventions have been empowered by faith and superiority of Western medicine and Western medical knowledge and technology, and devaluing of the knowledge and abilities of local populations. And then finally, health has been linked to social and economic development, but this connection is focused primarily on how improvements in health can stimulate economic development while ignoring the impact that social and economic development have on health. So thinking then, like I mentioned earlier, these ethical parameter guidelines that were created not that long ago, and they were largely created by people from high income countries. And it turns out we don't actually know really what the host countries think about these short-term medical mission trips. So what ethical concerns do they see about these short-term medical mission trips? And it turns out few studies have actually asked the question this. I'm going to say few studies published in high income countries or that have been published in high income country journals, because of course, this doesn't mean these discussions haven't happened, right? It just means they haven't been necessarily published in like the BMJ or something, or the Lancet. Okay, so few studies have actually asked, which I'm also going to point out is reflective of Packard's 6 persistent trends, right? That it's a one directional and have come from a high income country and been put upon the host country. So when we think about the asking of what ethical concerns the host countries see about these short-term medical mission trips, again, very reflective of colonial medicine, what they're saying as concerns. So a recent study evaluated best practice guidelines written by people from high-income countries from the perspective of host countries who have participants who have knowledge of short-term medical mission trips. Largely, these were interviews done in Honduras, Malawi, and the Philippines, because these are the countries with the highest number of U.S. volunteers going on these short-term medical mission trips. And Honduras is actually the most frequent country for North Americans going. And some common themes that came out of these interviews was that there was a desire by host countries to have more structured guidance for these short-term medical mission trips. They wanted volunteers to have a better understanding of the local and cultural context. And as this participant from Malawi said, teams are arriving without a full understanding of the local context, including, for example, cultural differences, local disease prevalence, which includes rates of non-communicable diseases and pertinent social issues, including gender-based violence. Another common theme that arose was that volunteers from high-income countries prioritize providing clinical care during short-term medical mission trips, but local hosts ideally want volunteers to assist with capacity building. So there's a disjuncture there, right, with what volunteers want to be doing and what the hosts want them to be doing. So thinking then about capacity building, because this is one of the themes that emerged in that study, capacity building is this idea that partners with established experience build knowledge or practice in communities that are less resourced. So this could be a workshop or mentoring, et cetera. This is very one directional in some ways. So that's why other people have proposed this should be capacity sharing. And that, as this quote says, more overtly recognizes the function of all collaborators learning from one another. All expertise from diverse areas have value, and operationally requiring a joint effort to create new knowledge, resources, and skills from those combined experiences. Another theme that arose from this study was that photography was a particularly sensitive topic for host communities and host countries. On the negative side of things, the study found these photos may be used to illustrate the worst in terms of living conditions or medical conditions in a host country when the health professional returns home. The photos can also be used by volunteers to demonstrate their experience. And instead, thinking about appropriate uses when consent was involved, when consent was obtained by people within the short-term medical mission trip by the host community. Right. And so the conclusion for these interviewees was there should be a separate code of conduct for taking photos by visiting healthcare professionals. So this was a really key sort of area for them. So some things that came out in addition to sort of how to ethically engage in a short-term medical mission trip that again came from host country participants in these is that there should be a volunteer code of conduct. Then I sometimes call this in my class right? You need some sort of contract, like as a volunteer going forward, this is what I know I'm going to be doing. This is what the host country says I'm going to be doing. We're in agreement about what's going to be happening when I'm there. So everyone's clear about the role that they're playing. So there's a volunteer code of conduct and everybody's clear about what they're doing and just as importantly, not doing. Okay, there could be health professional volunteer consent and waivers, pre-departure survey for a host country and short-term medical mission trip to complete together. Patient information sheet, consent referral form for foreign health professionals to be able to refer back into local health system. This is often a concern that these sort of short-term medical mission trips treat somebody and then it's kind of lost to follow-up. So having some very active of working within the healthcare system that's in existence for these short-term medical mission trips. And then again, because photos were such a concern, having a photo release form. So Lasker et al. Looked at existing guidelines. And again, most of these were developed by high-income country or people from high-income countries, but I still think they warrant to really keep in mind. And these are sort of seen as consensus principles across some the ethical guidelines that are in existence for these short-term medical mission trips. So one is appropriate recruitment, preparation, supervision of volunteers. There's also, really importantly, the host partner defines the program, including the needs to be addressed and the role of the host community in directing and teaching volunteers. This is hopefully to eliminate the power and structural imbalances and to equalize partnerships. There needs to be sustainability and continuing of programs. So sustainability is separate from dependence, right? That there's a sustainability, it doesn't mean dependence though. There should be respect for governance and legal and ethical standards. There should be regular evaluation programs for impact. This should be led and driven by the local community. And I'm going to put a caveat there. Sometimes the local community is rather stretched. So this, I think, also has to be taken very seriously into consideration of what that looks like and how it adds on to the time of the host community. And then finally, mutuality of learning and respect for all local health professionals, which is hopefully a reduction of neo-colonial ideas, this sort of saviorism model. Okay, so my final note before we go to questions is what makes for ethical volunteering in global health is not static. And while what I have presented are solid parameters to follow, one of the most important for those of us who are in a high income setting is to practice humility. Or put more bluntly, we should shut up, we should take a step back, and we should listen. So thank you. And I'm happy to entertain questions and maybe we can come up with some answers. I will stop sharing my slide. There we go. And I'm unclear. Do you want me to just see the hand raise? Is that how you guys want me to proceed? Or is that okay? So
yeah.
Oh, or Stephen, do you want to do it? I don't.
No, I would please take the reins. That seems perfect.
Okay. All right. So I see Philip has a hand up.
Can you hear me?
Yes.
Okay. Thank you so much for an extremely informative and thoughtful talk. I learned a lot. And I just wanted to say parenthetically, I really appreciate how you include sources on most of your slides, and I wrote a lot of those down and I'm going to follow up. So I have two questions. One is, what do you think of the distinction that the late Paul Farmer, founder of Partners in Health, draws between what he calls charity medicine? This is in the context of transnational medical assistance. Charity medicine on the one hand and the social justice model on the other. I'll just tell you my questions and you can answer any of them or none of them that you want to. The second question is, but you may not want to comment on this, do you consider Partners in Health an example of a more ethical model for practicing transnational medical assistance? Then my final question is more specific, and it comes because I'm a literature professor trying to write about a book by Edwidge Danticat, the Haitian-American author, and it is a family memoir in which she describes her uncle going to a short-term medical mission from the US, and the doctors there diagnosed that the uncle needs a procedure, basically a surgical procedure that it can't be provided in the host country, including by the visiting. It needs equipment and so forth. So the doctor says, I'm going to write you a letter and send your file, bring it to the American consulate, and they'll give you a visa to go get care. I'm just wondering if you have any idea how often that happens, that a visiting volunteer says, okay, you need care that I can't provide, there's not the necessary equipment here, I'm going to send you back to my country where there's the equipment and so forth to provide the care. Is that very rare? Or?
Okay, so I'm actually going to take a little bit of each, but I will
Okay.
I'm going to start with the last one actually,
All
because
right.
I would have to say, I don't know. I have not, I will say I have not read about that. More commonly, what I've read about and people have told me about when they've gone on trips is more of seeing somebody suggest a therapy that's either not sustainable because maybe they've brought a machine and the electricity isn't reliable where they're at, or nobody can repair the machine, right? So sort of thinking that maybe they've suggested something that either is not really accessible, not sustainable, or this gets to me more of the idea of, right, I've got a diagnosis that I can't do anything with, right? There's no therapy, there's no treatment, or it might not be accessible to me. And quite frankly, that's of course in our own country too, right? That there's all kinds of, we're in a high income country, but not everybody has equal access to the same sort of healthcare. So that I don't actually know how often it's been. Here, let me help you get to the United States for this care. It's more of that the care is not sort of available, and there might be a disconnect between the volunteer clinician not understanding what's available and what's not available. I'm going to loop then to the Paul Farmer's question. So the distinction draws between charity medicine and social justice model. So charity is one directional, right? There's no expectation of the person receiving charity to do anything with it, right? So that sort of negates this idea that what really needs to be happening in global health is that we need to be thinking about this is not a one-directional activity, and too much of it has been driven on this one-directional activity, and that reinforces this sort of colonial idea of what comes from the global north is somehow better than what's coming from anywhere else in the world, whether that's knowledge, whether that's skills medically, that we need to really trouble that and question that. So, and for him, that charity message versus social justice. Social justice is a horizontal approach, and the charity is that one at a time vertical. Now I say that sometimes you need a one at a time vertical. I'm not undercutting that. Like, honestly, one of the greatest inventions in the 20th century are vaccines, right? That's a total vertical intervention. However, that doesn't work for everything. So this idea of charity medicine as being one directional, I think, is what he's trying to really question, that we don't need charity medicine. We need this more of a horizontal approach. And I will say, and I will put this as a caveat, I give money to Partners in Health. They're one of the groups that I give money to. I have a lot of respect for the late Paul Farmer. Do I think Partners in Health is perfect? No. Do I think that they do a lot of work to really try to be ethical? Yeah. So I admire their work a lot, and I admire the late Paul Farmer's work a lot.
Thank you. Yeah, I also give money to them, and I wanted to see if you thought it was well spent. Just one quick follow-up, that part of the social justice model that Paul Farmer talks about for him is also keeping an eye on the underlying causes of health inequities. So, he says so much of it is caused by poverty, and so much of that poverty is caused by a history of colonialism and neo-colonialism. So that in a way, it even goes beyond some of the things in the sources that you talked about, that it's partly like trying to be informed about, keeping in mind and seeing how it might inform your practice of the history. Like, why is it that, how did these health inequities, why are they, why is it health outcomes so unequal here?
Mm-hmm. Yeah, no, well, being a historian,
Yeah.
I think knowing the history is profoundly important about going to where, like, things don't just happen, right? That people have made choices in the past, which means people going forward can make different choices. But I think it's fundamental to understand, why did somebody make those choices? And even if we don't agree with them, to understand why they made them, because that can help us sort of perhaps make a different decision going forward.
Thank you.
Yep. Does anyone else have any other questions? And are there questions in the chat? About the groups like Teach For, all right. So I'm going to confess for Sonia. I don't know enough about Teach for America. The one thing my son, who's a senior in high school, we talk about this a lot, because sometimes he'll come home and tease me that he's like, guess what, Mom, I could sign up for volunteer to go deliver babies in Honduras. Right. And so that's a family joke. So anyway, the whole thing though is this idea of what we talk about is if you don't have the skill set to do it, why do you think as a volunteer you can? Okay. And I give the example of, not Teach for America, but I was a volunteer my freshman year of college for Habitat for Humanity. Okay, I can't draw a straight line. I can't hammer a nail incorrectly. I had no business being a volunteer for Habitat for Humanity because I didn't know what I was doing. And I'm pretty sure somebody had to fix what I did, right? So volunteering, you still need to have the skill set. Now, maybe for somebody, it's, you know what, I need filing. Okay, filing is not sexy, but it needs to be done. Okay, and maybe I'm better equipped to file. I should not be delivering or hammering. And so that to me is sort of an underlying, do I have the skills to actually do the volunteer work that I'm doing, which goes back to this idea of scope of practice, but scope of practice thinking much larger. Okay, I've had undergraduate students say like, I'm going to go teach nutrition in somewhere. I'm like, can you do that? Probably not, right? And not to but I can do it somewhere else because it's easier or somebody needs it, which again, we need to question that idea of, is some care better than other? Does everyone need it? Because, okay, if it's needed, there's other resources in that community that probably can also be drawn upon. Jessica. I think you have your hand up, right? Jessica?
Got a question from the room.
Is that a question or?
Can you hear me okay?
Mhm.
I have two, we don't really have time for both of them, but I was wondering sort of what would be needed or who would be responsible or capable for shifting the STMM model to follow these ethical guidelines.
Mhm.
And then the other one is that the idea that there's obviously a lot of momentum from HICs to do these trips. Is there a way to sort of refocus that drive, the energy, the expertise, the money into something that's less harmful?
So to answer to your first one, how to shift the model to being more ethical, I think it goes to, I think two things have to happen so collectively. And one, I think there really needs to be a realization that we need to think about what global health is, those of us in the high income countries and the global north, right? We need to think about what is global health and to realize oftentimes we're talking about global health, we mean people from high income countries going somewhere else. And we need to say that and helping somewhere else or intervening somewhere else and saying, and with the assumption again, right, that that there's nothing where I'm going. So I think at a fundamental level, that needs to stop because that reinforces a power hierarchy and a knowledge hierarchy, then that needs to end. So fundamentally, I think it's just a rethinking about when we talk about global health, who are we talking about? Who are the actors and who are the recipients? And we need to question all of that. There's a famous Joanna Crane article where somebody essentially, and she's an anthropologist, and works in global health issues, and she's at a CUGH, which is a consortium for universities in global health, who are almost all in the high income countries. There's very few country or universities who aren't a high income country in that group. Anyway, the speaker is like, I think they were from Mexico City, a university in Mexico City. And he says, do I have to go somewhere poorer basically to practice global health, right? So we need to think about what is global health and to question who gets to do it and who kind of is the receiver of global health. And then the refocus and drive, I think kind of falls under that same area. And I think it really asks a lot of us to question what can I do to help? And maybe it's not actually going someplace. And I'm going to put a caveat on that. There really are people who can fundamentally help in a volunteer capacity and physically go somewhere. And I'm not undercutting that. I just think you have to be very clear about what you're doing and that it's you that can do that safely and effectively. Right. But then it could be, okay, maybe I shouldn't go like me, right? I should not be nailing into a wall ever. I can't even hang a picture. Okay. I am incompetent at this. I had no business doing that. Right. But there's something else I could maybe do for Habitat for Humanity, right? Could I open their mail, right? There's something else maybe I can do that doesn't physically mean I have to go into a certain space. I can stay in a different space. That there's physical things or even sort of clerical things. There's other ways that I can volunteer. They might not have the same photo op, right? Or they might not have the same sort of line on my CV, but they can be profoundly helpful. And I think we need to sort of think about that too, about how can I actually make a difference safely and ethically? And again, per my talk, right? Best intentions for me of going in and hammering, but incompetent. Okay. Oh, thank you, Judith Lasker, as I used your some stuff you've done. Thank you for coming. And I'm sorry, did I miss a question? John, did you have a question? I'm very quickly trying to scan your chat message. Was there a question?
More just a commentary.
Okay.
Having been out of the country, 3 different to Mexico, Haiti, and to Honduras. And each time it's more not going there to do the procedures, but teaching people how to do the cases.
Mhm.
And I might, as a surgery, in the Department of Surgery, watching residents go through training, there's less laparoscopic training, more robotic training. And that's the push, is that when you go to these other, with resource limited countries, you have to have have the ability to do these procedures in ways that you may not have been trained. And you may need to have somebody who has the expertise to help provide that.
Mm-hmm. So I will say, and you're probably familiar with, there's actually a fairly strong literature within the surgical literature about concerns about short-term medical mission trips about surgery, particularly because obviously if there's a group of people who go and they're performing surgeries and then they leave and people who are actually taking care of them don't recognize maybe some problems post-surgery or right, that the sort of notes aren't really left, whatever, that there can be problems taking care of the person going forward. I also always tell my students, I don't have patients, my students, that surgery is not an end. I think oftentimes, at least in this country where surgery is more accessible to a lot more people, right, we see surgery as an endpoint as opposed to your medical trajectory has changed. You still probably need follow-up. You still might need care. You might have a complication. You might be on drugs the rest of your life, right? There's a trajectory that is different, maybe the one you're on. And depending on where you are, that might not, that follow through, that next trajectory might not be a possibility. So yeah, thank you. Sort of thinking about that of training, but then also the follow-up for.
Right. But this is where we're not actually doing the procedures. We're actually assisting them and help them develop additional therapy and techniques. If I can teach a surgery resident to avoid a common bowel duct injury, I've just helped the next 3,000 to 5,000, 10,000 patients they've taken care of.
Thank
But
you.
that's, and it's but again, it's very, when you're resource limited, you have to be able to adapt and to use things that they have locally.
Mm-hmm.
Thank you. Great presentation. Thank you.
Thank you. Donfac?
Yes, correct.
Okay.
So mine is more of like a comment. I'm from a West African country. I mean, I've been in the US for a few years, and I'm actually glad this issue on, like ethics and what is, global volunteering. I'm glad you brought up some really great points as someone, like, especially with this distinction between high income and low income earning countries. I mean, what is that? I mean, I come from a country where, I've seen a lot of rich people. Like people that are that earn way more than in the United States. And I don't know why they have like these terms or these labels. So, I'm glad you actually brought up this point. And like, it's a good thing that the focus on the mindset on what volunteering is or on what charity is shifting, because I saw a social media post, especially when it comes to the photographs, and I was really upset with the type of pictures they put out there. And I made a comment and I was like, why do you guys take these pictures? Like, this is not how all of Africa is. Not everyone is living, like in a poor state or, and I was crucified for that. And people were coming at me saying like, oh, like some care is better than no care and, all that crazy stuff. So I'm actually glad these issues are coming up and that the mindset is shifting. And I hope a lot of students will be able to listen to more lectures like this and know what they're getting into, when they're saying, oh, I want to go help. And why do you feel like you need to help out of your country? Like, have you tried helping in your own country before trying helping out there? Like, so you just need to know the different situations that people are in, like the cultural differences. And yeah, so just great presentation, and thanks for bringing up all these great points. So
Thank you. Thank you for your comments.
Yeah.
Did someone else have, and as you were talking, I was trying to remember the name of an article. And I'm blanking. So I will send it to Jessica, and then Jessica can decide if she wants to send it out to the group. Because of course I teach it and I've completely blanked on the title of the article. So I will send it to Jessica.
thank you.
Okay. Does anyone else have, I'm scanning really quickly. Sorry.
Are
Does
there any
anyone?
further, any further questions?
Looks like there are any questions left. Anyone last minute things? No? Okay. Well, thank you so much for your time, Dr. Rodriguez.
Thank you. Thank you so much for inviting me. And have a lovely rest of your day.